I think ruxolitinib in myelofibrosis, really should be initiated, as early as possible in probably the vast majority of patients with myelofibrosis. The exception to that are the individuals that really truly have low risk, but very much of a low symptom burden. All of the aggregate of the experience from both the trials, but the real world evidence would tend to suggest the earlier we use it, the better, because it not only has this impact on spleen and symptoms, but that I think is just one superficial lens on the benefit. There really is a progression free survival benefit that's more difficult to quantify, but is very real. And we obtain the majority of that benefit the earlier we use the therapy. When we look at the data from the comfort studies and the earlier phase one, patients who have very advanced disease, when we start ruxolitinib, they're going to benefit, but it will be less than the individual that has less massive splenomegaly or less severe cytopenias. So I think earlier is clearly better. The clinical trials started with the intermediate 2 and high risk patients, but that was very much of an arbitrary decision. That was an extension of the phase one. The phase one, first in human, let's start with the highest risk patients. But there's really been nothing over time to suggest that there is a need to not utilize that therapy in symptomatic low risk or intermediate 1 risk patients.